This video is on the respiratory physical exam. Like all our exam videos, this video will focus on the main steps involved and what abnormalities at each step may mean, so what pathologies can cause abnormal results in your physical exam. We will provide tips onto exam technique, but this will not be the focus of the video. So as with all exams, you must start off with general observation. So that's looking around the room and looking broadly at the patient. So see if they are on any oxygen. Did they have nasal prongs or any Hudson masks? Are they connected to any IV fluids? Are there puffers on the table nearby? Is there a sputum jar? Is the jar filled with sputum? And does the patient have any obvious signs of upper airway obstruction, such as stridor, which is like an inspiratory whooping sound? Then more specifically, you can look at the patient. So observe the patient for any signs of respiratory distress, such as tachypnea, so increased respiratory rate, as well as use of accessory muscles. This could be the sternocleidomastoid, the pectoralis major, as well as nasal flaring. Then we're ready to start looking at the different parts of the patient. So we can look at the hands, start peripherally as always, looking for any clubbing, any tar staining, indicative of past smoking, any cyanosis, a peripheral cyanosis, any muscle wasting, any asterexis. So this is where you test for carbon dioxide retention, where you ask them to cock their hands up and then you push the palms and then see if it flaps. Then you can look at the face, looking for netosis, meiosis, and anhidrosis, which should be part of Honus syndrome, as well as looking in the mouth, looking at the tongue for any central cyanosis. Then we're starting to palpate the patient, so assess for any tracheal deviation. As seen in this picture, you can see the trachea is deviated to the left, and this is causing accentuation of the sternocleidomastoid. Now the trachea could be deviated because something's pushing it away or something's pulling towards it. So the trachea will move towards a lung collapse or significant fibrosis, as there's essentially less lung there, so the trachea moves to equalize the pressure. Similarly, the trachea could be pushed away by fluids, such as in the case of a massive pleural effusion. Smaller pleural effusions will not cause this, or a tension in pneumothorax, so basically a massive pneumothorax. Then observe the chest for any scars, such as a median stenotomy, which would be present in, for example, a cardiovascular bypass surgery, any visible veins, any cachexia, so severe muscle wasting, which could be indicative of cancer, and any chest wall abnormalities as shown here. So barrel chest, often associated with chronic COPD or pulmonary fibrosis, as well as chest wall deformities, such as pectus excavatum and carnatum, as well as kyphoscoliosis. Then you can palpate the chest, palpating from behind, assessing for chest expansion. You're expecting it to be 5 centimeters, your thumbs move 5 centimeters apart, and it to be symmetrical. Make sure you're not having the thumbs too firmly placed on the back, because you want to have some looseness so that the thumbs can move apart. If it's asymmetrical chest expansion, then one side would expand less than the other. And this could be due to unilateral pathology, such as collapse or atelectasis, consolidation from a pneumonia, or a pleural effusion, which we will explore more in a later video. If it's symmetrical but reduced, so not 5 centimeters, this is due to bilateral pathologies, and this could be due to COPD or pulmonary fibrosis. Then percuss. Resonant is normal because air is in the lung. However, if there's too much air in the lung, the percussion is hyperresonant, and this is indicative of a pneumothorax. Dull to percuss is consolidation, such as from pneumonia, and specifically a stony dullness is present in a pleural effusion. In terms of doing your exam, percussion is probably the most important step to master technique-wise, because it's very easy for the examiner to tell whether or not you're percussing correctly. It's harder for them to assess whether or not you're looking at all the right things, or if you hear what you meant to hear. Which leads on to the next point, auscultation. So breath sounds can be either vesicular or bronchial. Intensity you report as normal or reduced, and notice if there's any pleural rub, if there's any pleuritis. Then additional sounds, or adventitial sounds. You can hear a wheeze in COPD or chronic bronchitis or asthma due to narrowing of the airways, and as the air goes through a narrow airway, it makes that wheezing sound, typically heard in expiration. Coarse crackles are present in bronchiectasis, and fine crackles are present in fibrosis. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.